distinct pleasure now to invite Dr. Mahajan, who will cover and the first part of the talks, which is cerebrovascular hemodynamic assessment, and kind of lay the foundation of everything else we're going to talk about in the next 2.5 hours. Rahul, the floor is yours.
Great. Let's see. Can you guys hear me okay?
Yes.
Perfect. So thanks, Arti, for having me, introducing me to talk here. So I think I get the pleasure of speaking about a topic here that's probably the foundation of TCD clinical use, looking at hemodynamic assessment. That's this. I have no disclosures relevant to this talk. And just to sort of narrow the focus a little bit, specifically what I'll try to stick to is talking about the estimation of vascular stenosis by TCD and the estimation of collateral activation of collateral pathways by TCD. So fairly well-established uses of TCD in vascular neurology and in the ICU. And as always, it's nice to maybe start off with a quick case to sort of get us into the sense of the kinds of patients we're talking about and how we can use TCDs to inform our clinical decision making. So we start with a case of a patient who's 53, has no known medical history. This is a real patient I took care of in the ICU. He's 53, no medical history, no vascular risk factors that he knew about, construction worker, came in with a right MCA syndrome, found to have a tandem ICA and M1 occlusion on the right side. Initially went to an outside hospital and then transferred to our center for consideration of intra-arterial therapies. His stroke scale at the other hospital was 7, with left-sided facial droop, drift in the arm, drift in the leg, and sensory loss. CT head was without hemorrhage, so he got TPA, and the CTA showed a tandem occlusion of the distal right M1 into the M2 and the right ICA cervically near the bifurcation. He got TPA and then almost immediately had improvement in his clinical symptoms. By the time he got to our hospital, his symptoms had completely resolved with a stroke scale of 0. And knowing that he was somebody with a large vessel occlusion at risk for further neurologic decline or fluctuations in exam, as we routinely do, we admitted him to the neuro ICU for closer monitoring. A couple images relevant to his case. So we can see the right distal M1 into the M2 occlusion here in the first image. On a coronal section here in the CTA, we can see basically the ICA on the right side is out completely starting at the bifurcation. And then somewhere near the petrous portion of the right ICA, we start to see it reconstitute here in the last image. And this is the imaging he had. Now, given his improvement in clinical status, one could argue, why don't you get a repeat CTA to see if he's recanalized? And that's a worthy consideration. He had just gotten this radiation and contrast bolus, a couple hours before he arrived to us. And so given that he had improved and not declined, we elected not to get a repeat imaging, and instead he got TCD. He got an emboli detection study, which I'm sure we'll talk about at another conference, which did not show ongoing embolization to his right MCA. And then more relevant to this hemodynamic monitoring topic, we get a complete study looking at the circle of Willis velocities and waveforms. So starting on the contralateral side on the left side, we see fairly normal waveforms with a brisk upstroke, stepwise downstroke, low resistance waveform, normal mean velocity, normal pulsatility index, and a fairly unremarkable insonation of the left MCA. The left terminal ICA, I would say similar story, essentially normal waveform, normal velocities, normal pulsatility. In the left ACA, we start to see some abnormalities here now. So in the left ACA, we see an elevated velocity. So the mean flow velocity is well outside the normal range at 102. The pulsatility index is normal, still a low resistance waveform, and then maybe we're starting to see some evidence of a sonographic bruit here at the bottom of the waveform here. So elevated velocity in the left ACA. The left PCA, we have an elevated velocity with the mean flow velocity of 71, so fairly elevated for a PCA. This is and otherwise unremarkable. The vertebral artery, also the velocity is a little bit high on the right vertebral. The basilar artery with a velocity of 93, definitely elevated velocity is there as well. The left vertebral artery, mean flow velocity of 80, elevated as well. The other thing I should mention is in this machine, the direction of flow, all the waveforms are upright, and the direction of flow is shown by this little symbol on the top, showing flow away from the probe if the arrow is pointing away, and flow towards the probe if the arrow is pointing towards, but the waveform is always upright. And so this is flow away from the probe and the vertebral artery as expected in a normal flow direction. Now we get to the main portion of the pathology. So in the right MCA, we notice a drastic change in the velocity and the waveform qualitatively. The direction of flow is normal. We see maybe some delayed flow acceleration, although it's close to normal here, but certainly it's a dampened waveform here. The mean flow velocity is, it's a pulsatile flow, but it's certainly abnormal where it's low. And so we notice basically pulsatile flow with a low velocity and normal PI in the right MCA. The right terminal ICA, it's a similar story as the MCA. The velocity is quite low, the PI is normal, the flow direction is in the expected direction. And then the right ACA, we see screaming high velocities, the velocity of 161 in the right ACA. And again, the flow here now is towards the probe, which is retrograde to the expected direction. So we have reverse flow in the right ACA with a very high velocity. And then if we recall, we also had a high velocity in the contralateral ACA. So a pattern that adds up to a flow across the ACOM, having cross-filling from left to right collateral flow. And then the right PCA, we see elevated velocity, more so than we saw in the left PCA. The left PCA was in the 70s. The right PCA is up 99, close to 100. So very high velocity for a PCA. And otherwise, low resistance waveform in a normal direction in normal PI. The ophthalmic artery on the left side, so we've switched to an orbital window here. So a elevated pulsatility index, so high resistance waveform as expected for an ophthalmic artery. And then the flow direction is towards the probe in the orbital window, which is anterograde flow for an ophthalmic artery. So essentially normal inclination of the left ophthalmic. And then in the left siphon, so we've increased the depth to get the carotid siphon deep to the ophthalmic artery there or through the orbital window. On the left side, essentially normal. On the right side, we see a very different story. The right ophthalmic artery, we have a low resistance waveform, and the flow is away from the probe in the orbital window. So we have reversed flow in the ophthalmic artery, now showing characteristics of low resistance waveform consistent with reversed ophthalmic flow and internalization of the ophthalmic flow. The siphon on the right side, so if we increase the depth on the right, we see some increased, well, the velocity is low, sorry, so similar to what we've been seeing on the right side. So ICA velocity is low, but not terrible. And otherwise, the direction is normal and the PI is normal. So all in all, there's our table of all the summarization. But in a patient here who's clinically improved, maybe we feel a little bit reassured that the velocity in the right MCA is pulsatile with a decent upstroke. It's not, completely out, and that we've seen the activation of multiple collateral channels, right? So he's gotten slow flow through the right ICA and the MCA, but he is able to establish collateral flow through a reversed ACA, showing left to right cross-filling. He's got retrograde flow on the right ophthalmic, so it's showing ECA to ICA collateralization. And then we also see evidence of posterior to anterior PCOM flow because of the elevated velocities throughout the posterior circulation, especially in the right PCA compared to the left PCA. So all of that supporting, he's got multiple channels of collateral flow, helping him supply that right hemisphere. We monitored this patient in the ICU for 24 hours. His exam continued to be stable, and he was able to transfer to the floor and continue his stroke workup. So some basics, as to this audience, I don't need to explain in too much detail, but essentially, the standard of care for TCD interpretation involves mostly these metrics. So the peak systolic velocity at the highest velocity at the corresponding with systole in the cardiac cycle. We have mean flow velocity, which, again, to clarify, can be the area under the curve, either of the envelope of the waveform versus a TAM-V, which would be a time average mean, which actually takes into account the intensity of each of the individual frequencies at each time step. For TCD, that peak flow, this time average peak or time average systolic velocity is the one that's generally used when we talk about normative values for mean flow. The end diastolic velocity at the end of the waveform, and then the pulsatility index, which I'm sure we'll hear about in subsequent lectures, often thought to correspond or have some correlation with the degree of downstream resistance from the area of incination, with a formula here. So multiple physiologic and pathologic variables influence these variables. So these velocity variables and the pulsatility index, age, sex or gender, hematocrit, and related to that, the viscosity of the blood. So as we see in patients with anemia or sickle cell anemia, you might see elevated velocities. Carbon dioxide, a potent vasoconstrictor and vasodilator, will influence these. Blood pressure, even with an intact autoregulation system, you can have some influence on the velocity, and especially the PI can be influenced. Fever or hypothermia. Mental activity and motor activity can cause changes in TCD velocity, so giving rise to things like functional TCD. And then obviously pathologies like ICP stenosis or stiffening of the arteries and arteriosclerosis will affect the waveform. In estimation of stenosis, we're really using the theoretical underpinnings from the Spencer-Reid curve, whereby as the degree of stenosis increases, going from right to left here, initially the blood flow is able to be maintained at around, when we get to moderate to severe stenosis, somewhere around the 70% stenosis part, we start to get limitations in flow, and the blood flow begins to decrease with worsening stenosis. Velocity tends to increase throughout this range as the degree of stenosis worsens, until we sort of reach a peak. And when you have severe retardation of the blood flow, severe degradation of the blood flow, now the blood flow velocity can no longer increase to maintain flow. It starts to decrease, and you're on, quote unquote, the other side of the Spencer-Reid curve, which we try to capture through interpretation of the qualitative waveform and the pulsatility index. So in terms of normative value, Dr. Tegler and others have published normative values in terms of values for the velocities for the mean and the systolic and the PI, by age and by sex, in a relatively healthy population. So these are patients with relatively normal BMI, blood pressure, without known vascular risk. These provide a basis for our interpretation of TCD velocities in pathology. And so in estimating, some of these slides are not translating well to Google from PowerPoint. In estimating the percent stenosis, generally, the variable of interest is velocities. So we can have, there's various publications that have tried to develop cutoffs for the velocities that would predict percent stenosis. So in the era of the WASID trial, which is a warfarin versus aspirin trial, there was a lot of interest in identifying patients with greater than 50% stenosis in their intracranial arteries. And so initially, I think probably extrapolating from the carotid literature and the carotid experience, studies looked at peak systolic velocities and cutoffs for various peak values to predict percent stenosis greater than 50%, or predict less than 50%. And it's had decent performance. And then more recently, the field moved towards using mean flow velocities for intracranial vasculature, which seems to make more sense, since our sample gate basically incorporates the entire vessel diameter, and makes sense to be talking about the mean velocity instead of the peak, because we're not able to detect just the peak the way we can in a carotid. Looking at the mean flow velocities, so there was a large trial, the SONIA trial, which was a prospective trial essentially validating TCD and MRA assessments of vessel diameter compared to a DSA, a catheter angiogram, as a gold standard. And that put forward some cutoffs, and we can see the performance here. The ones with the asterisk are the original Sonia trial sort of cutoff. So mean flow velocity greater than 100 as a cutoff to detect MCA stenosis greater than 50%. And updates to this literature have tried to extend these cutoffs to look at not just 50%, but 70% stenosis, and look at not just the anterior circulation, but also the posterior circulation, the basilar and vertebrobasilar system. Besides the velocities themselves, other variables people have looked at are the stenotic to pre-stenotic ratio, that's this SPR, or just looking at very low velocities for, again, when you're have severe stenosis and you've dropped to the other side of the Spencer-Reid curve where you're getting very low velocities. That could also help you predict, especially when you're looking for severe stenosis greater than 70%. So I think with these cutoffs, we can get decent performance, especially in terms of negative predictive value and ruling things out. For positive predictive value, no matter what cutoff you use, you're somewhere in the 40 to 60, 70% chance of percent range. And there's always a trade-off, obviously, in terms of increasing specificity versus losing sensitivity for these criteria. Another sort of framework for this has been the TIBI grades, what Dr. Alexandrov here. And this is sort of a semi-quantitative method where you're using waveform characteristics to give a grading to the, this is looking at recanalization after IV thrombolysis, but so, this grading has been used in other settings as well, not just post thrombolysis, to look at the flow through a vessel and give a characterization of the vessel flow. So that's essentially, fairly well-established methods of characterizing stenosis using TCD. Looking at collaterals, there's a few different things. So it's similar to what we saw in the clinical case there. Really, what we're looking at with TCD is collateral status at the circle of Willis. So you can examine the reversal of the ophthalmic artery, cross-filling across the ACA, or try to characterize a flow, posterior to anterior flow across the PCOM. And our patient sort of displayed all three of these. Additional collaterals that you could try to assess with TCD are flow diversion, which is basically looking at compensatory increases in, for example, an ACA in the setting of an MCA occlusion. And this is thought to represent perhaps activation of leptomeningeal collaterals. So if your MCA is occluded, you may see increased flow velocity through the ACA as the ACA takes on extra blood flow for leptomeningeal collateralization to the MCA, occluded MCA territory. And that's again, these have various different characteristics in terms of how well these criteria work. So in terms of flow across the ACOM or reverse ophthalmic, these TCDs seem to work really quite well, and these are well validated and highly accurate assessments, and fairly routinely used in clinical use. For assessment of posterior to anterior collateral flow, one, it's more difficult. Some of the criteria call for actual intonation of the PCOM artery itself, which you can imagine is difficult. And there's different criteria in terms of flow on one PCA versus a different PCA, or flow of the PCA compared to a different baseline. And then in terms of leptomeningeal collaterals, really is quite varied definitions across the literature. And how well, the TCD phenomenon is flow diversion in terms of seeing elevated velocity in one artery in the setting of a ipsilateral artery occlusion. That does seem to correlate well with assessment of leptomeningeal collaterals by DSA. But that said, again, there's a lot of heterogeneity in the literature in terms of definitions used, but it seems to work well enough to correlate with clinical variables such as infarct volume and even modified Rankin score, as you would expect for something that's assessing collaterals. Um, I'll just finish with one or two more slides, and then I'll be able to answer these questions. Um, in terms of TCDs, it seems like there was the heyday of TCDs in clinical use. And, obviously we're in sort of a resurgence now, but in the mid 2000s is where we were seeing society guidelines. The last ones from the AAN were in 2004, which went through detailed, clinical utility of TCD in various clinical settings. And then in 2009, we have, still standing AHA guidelines in terms of use of TCD and interpretation for hemodynamic assessment. And then more recently, we have ASN based guidelines, and that's more about monitoring in an ICU setting, not quite the topic that I'm covering here. So just a few gaps that I think I was fortunate to speak to one of the more established applications of TCD. I think we have normative data in healthy populations, but the patients we assess in the ICU are often not healthy and have various vascular risk factors coming with various pathologies. And it would be, I think, helpful to start to get larger data sets of what the velocities look like in these sicker populations. I think there's continued issues with standardization of both the assessment of the TCD data and then the interpretation in terms of use of angle correction, which varies geographically. Things like, as I mentioned, flow diversion or assessment of PCOM collaterals. There's varying definitions used throughout the literature, so then it's hard to really come up with performance of these because there's different definitions, different papers, so then we can't really do meta-analyses or come up with robust validations. And then the next one is a little bit of a hypothesis here. I think it would be helpful. For example, we gave elevated velocity as a criteria for defining stenosis. And then in the next slide, I said elevated velocity as a criteria for establishing flow diversion. And in a clinical patient, you really don't, if I have a patient with an severe MCA stenosis and their ACA velocity is also elevated, is that because of flow diversion or is that because they have multifocal stenoses because of ICAD? There's really no way of assessing that through TCD directly. We look at the CTA and try to develop sort of, a three-dimensional picture of the patient. But it would be interesting if we were able to maybe use some of the imaging TCD, developing technologies to start to assess the diameter of the vessels directly, which would, one, help us in interpretation of things like I just mentioned, flow diversion versus stenosis, but would also help maybe with some of the other topics that folks will talk about in terms of correlating flow velocity to actual blood flow, right? If we had an accurate assessment of the diameter, you could start to get to quantitative blood flow measurements. And then I think other obvious things to do are moving beyond just velocities and pulsatility index to actual ML and other more sophisticated analyses of the waveforms. I think there's a lot of information in the waveform that gets left behind when you reduce it to a handful of numbers. And then I think, given sort of, I think what we've all seen with the billing and sort of scaled back reimbursements for TCDs, it would actually be helpful to have some updated guidelines for the clinical utility of TCD in various clinical settings. And I think the applications for TCDs should be growing, not shrinking. And I think the societies have a role to play in advocating for that.